Hi there. I'm going to do a short presentation on implementation science for those of us in pediatric radiology who are looking to participate in ultrasound for volvulus implementation. All right, so no disclosures. And the point of this presentation is to describe the development of implementation science as a field, explain how frameworks are applied, and list examples of implementation science in pediatric radiology. To start off, this is a case example of a 4-year-old with 2 months of leg weakness and pain. We're looking at an MRI of the knees, showing several abnormal findings. We see along the femurs that there is hemorrhage under the periosteum. We see that there's also edema, this bright T2 signal in the trabecular bone of the femurs, of the metaphysis. And we also see edema in the muscle too, in the quadricep muscles, this bright signal here. So these features are characteristic of scurvy, which we know as vitamin C deficiency, which yes, does still occasionally happen today. It was discovered in 1601 that citrus can cure scurvy, but it wasn't until 1747 that a randomized controlled trial was performed to test citrus in the treatment of scurvy. By 1795, the British Navy had adopted the use of citrus to prevent scurvy, and it wasn't until 1865, almost 250 years after the original observation, that the British Merchant Marine also adopted the use of citrus to prevent scurvy. So this is an example of the long, tremendously long, sometimes centuries long lag between information and understanding and actually putting that into practice to help patients. But this is not just a problem of hundreds of years ago, this is also a problem today. So looking at this second example of a care model for bipolar disease, this is a research project that was testing the hypothesis that a collaborative care model can improve treatment of bipolar disorder. This was a 3-year randomized controlled trial with 11 participating hospitals across the nation. It was grant funded, and it showed that there's a significant improvement in patient mood and function during this program at no additional cost to the healthcare system. However, when we look at implementation of these findings in practice, actually none of the participating sites were using this system 1 year after the research ended, despite outstanding results and no additional cost. So there's a big disconnect between what we know and what we do. You can think of this as a cake problem. So think of research and the findings and the evidence that research gathers as a cake, a beautiful thing that's been made to try to help people. But getting the cake to the people is a different thing entirely. And so this is where implementation science comes in. You need tools to get the cake to the people, right? You need serving tools, you need plates, you need forks, napkins, candles for the birthday party. And all of this together is what implementation science is designed to do, to bring the products of research to the people who need it, who would benefit from it. So using those tools to connect the cake to the kids hopefully results in a happier group of kids and a healthier group of kids in our situations. So this is a fairly new field. If you haven't heard of it before, that's probably because it's not very old. It was begun in the 1990s as people were recognizing the long lag time between knowledge and practice. So it's an average of 17 to 20 years to adopt a new practice, and less than 50% of evidence-based medicine actually becomes practice. In the 1990s, implementation science was developed to bridge that gap between research and clinical practice. When we think about what research is intended to do, it's often hypothesis-driven, and it tests the validity of an idea or a concept in a controlled environment. One step further than that, effectiveness studies test, does that same concept work in a natural environment, in a less controlled environment? So can you take those research results and do they still hold true when they're not being tightly controlled in a research environment. One step further than that is what we're talking about now, which is implementation science. And specifically, implementation science focuses on the environmental factors that need to be in place to promote uptake of this evidence into practice. The tools for implementation science include frameworks, barriers and facilitators, and strategies. So we'll talk a little bit about those in the coming slides. And overall, the idea is to develop a common language and generalizable methods around implementation science so that we can all learn from each other and publish our work, and it can be used to benefit other practices as well. So frameworks are often the core and the first step of an implementation science project. Frameworks are ways to characterize a change environment. So again, focusing on the environment. And determinant frameworks is one class of frameworks, which focuses on the aspects of the environment that will influence or determine the implementation outcomes, how well it takes root. Theoretical frameworks borrow theory from other fields to understand how implementation can succeed. And then finally, evaluation frameworks focus specifically on the measures of success of an implementation. And so any given project may use one or more frameworks, and there are many to choose from. So these are three sort of classes of frameworks, but over 200 frameworks have been published in the literature in successful implementation projects. And so this large number represents people adapting frameworks to the local environment for success. And so there are many models to choose from, as well as options to customize a model to your specific situation. So a number of these frameworks are published in a paper summarizing what's in the literature. And so to quickly review what some of the determinant frameworks look like, just to give you an example of how these are structured, there's three examples here, and the determinant frameworks are focusing on the characteristics of the implementation object, or like the tasks to be implemented, characteristics of the users or adopters, such as the healthcare practitioners in our healthcare models, characteristics of the end users or the beneficiaries of the improvement or the implementation project. So that is often patients in our environments. Characteristics of the context of the environment, and then characteristics of the strategy that you might use to facilitate implementation, and finally outcomes, how we think about outcomes in a framework. So specifically looking at this last example here from Grohl et al., characteristics of the implementation task, essentially object, would include a very kind of vague summary as features of the innovation. So that allows some customization of what features of the innovation are important, depending on the specific task you are trying to implement. Characteristics of the users or adopters. So this would be features of the professionals who would use the innovation. Focusing as well on characteristics of the end users, which would be a class of patients. Characteristics of the context. And so in this situation, this model is looking at features of the social setting, including attitudes of colleagues, the culture, the leadership, and the economic, administrative, and organizational context. So those are all factors that can either sink a project or promote a project, depending on how well the goals are aligned with what the social setting and these other factors bring to influence the project. Characteristics of the strategy or other means of facilitating implementation include features of the methods and strategies for dissemination. And then outcomes in this situation might be implementation of new evidence guidelines and best practices or procedures. So that's one that sort of focuses on the healthcare setting and specifically the social setting features. I also want to go over this conceptual model, which is a slightly different focus and involves some of the other tools that we would consider and models that we would consider in implementation science. So in this case, we are looking at innovation attributes. as the characteristics of the implementation object. Again, a bit vague, so it can be customized to each individual situation. And then characteristics of the users or adopters would include some aspects of the adopters, such as psychological antecedents, nature of the adoption decision, assimilation by organizations. So a little bit more detailed than the previous example, which just described features of the professionals. In this framework model, there is not a description of specific characteristics of the end users. The characteristics of the context in this framework include the inner context and the outer context, which is something that you will see in implementation literature and projects. So the inner context is defined as sort of the organizational or the local antecedents and readiness for innovation, whereas the outer context might be interorganizational networks, political directives, things outside of the immediate environment that might affect how the change is assimilated. Characteristics of the strategy or other means for facilitating in this framework include influences such as opinion leaders, champions, network structures, and looking at those across a continuum from diffusion of the change to dissemination of the change. And outcomes here being successful diffusion, dissemination, and implementation. So there are some terms in here that may be familiar, but may have some slightly specifically different definitions within implementation science. So we'll talk about those in a few slides as well. So moving on from frameworks to talk about strategies. So strategies are the methods that you would attempt to use in implementing your change. And so like frameworks, there are many different strategies to choose from and can be customized to your exact project and local environment. Many of these strategies have been collated in this paper describing expert recommendations for implementing change, or ERIC. And the idea behind the strategies as well is to provide a common vocabulary for the work that people do in implementation science. In the ERIC publication, there are 73 discrete strategies which fall within 9 clusters. And just to show you an example of how these are organized. So this table within this paper lists all 73 of these discrete strategies, and just alphabetically to show you an example of what these look like. So a strategy may include accessing new funding, which has a fairly straightforward definition of accessing new funding. Assessing for readiness and identifying barriers and facilitators is often core to an implementation project. And so this defines a bit more, in a bit more detail what that means. So assessing various aspects of the organization to determine readiness to implement, focusing on barriers that may arise, and as well as strengths or facilitators that may be used in the implementation effort. And then auditing and providing feedback is often something that needs to happen during a process, and this would include collecting and summarizing clinical performance data, and giving it to clinicians and administrators as feedback to assess how well the implementation is going. So discrete strategies that can be used, and again, this is really meant to develop a common vocabulary and to be able to share methods between institutions. Finally, outcomes. In implementation science, the outcomes that we focus on might be slightly different than what we would focus on in improvement projects or research projects or even customer service oriented projects. So skipping to the middle panel here, service outcomes are things that we often think of as quality pillars. These come from the Institute of Medicine and include our well-established quality pillars in medicine: efficiency, safety, effectiveness, equity, patient-centeredness, and timeliness. Client outcomes, I think we tend to not focus on quite as much in as direct patient care providers, but others in the hospital do focus on those. And then circling back here to implementation outcomes: acceptability, adoption, appropriateness, costs, feasibility, fidelity, penetration, and sustainability. So these are outcomes that are often important in implementation projects. What do those mean? So acceptability is defined as representatives in a project agreeing to implement the change. So we all find it acceptable and agree to implement it. Adoption refers to the intention or actually putting the practice into place. Appropriateness assesses, is it right for the environment or the population? Costs should be assessed. They may increase or decrease. It may reflect cost to the institution or to patients and families. Feasibility refers to the extent to which it's actually possible to implement the change in the environment. Fidelity reflects how close the implementation in practice follows the intent. Penetration refers to how widely the change has been integrated. And finally, sustainability reflects the extent to which the new practice continues on its own once the project is done. To look at an example of how this can be done within our field in pediatric radiology, I give you the example of patient shielding. So by 2016, there was a body of literature suggesting that gonadal shielding doesn't offer benefit to patients like we once thought it did. This evidence was followed about 3 short years later by policy advice from the American Association of Physicists in Medicine, as well as the American College of Radiology, which advised against shielding. And 4 short years later, national recommendations came out from the National Commission on Radiation Protection, as well as the Food and Drug Administration, to advise against shielding. So some fairly substantial policy recommendations from both professional organizations as well as national organizations. However, putting that into practice is not the same thing as knowing that you should do it. So this paper describes exactly that process, from evidence to practice, implementation and evaluation of the discontinuation of patient contact shielding in pediatric radiography. So a paper from a group in Australia that details how their process worked. So they used a model called the Capability, Opportunity, Motivation, and Behavior model, or COM-B model, and combined that with a theoretical domains framework. So among all the frameworks there are to choose from, these two, this model and this framework, fit their local environment the best and the tasks that they had before them. And so together, this informed the development of their implementation strategies. How does it actually work? So to begin with, identifying barriers and facilitators is very useful to inform the strategies. So in these examples of TDF domains from that theoretical domains framework, we include knowledge, environmental context and resources, belief about consequences, and behavioral regulations. And so each of these have a potential barrier around knowledge. There's the uncertainty about evidence and patient expectations, which can be addressed with training and resources. In the environmental context and resources, there is access to shielding and habitual use of shielding. And so one way to remedy that is to modify the environment to change automatic behaviors. Belief about consequences may manifest as concerns regarding consumer resistance, patient and family resistance to the change. And so a way to address this would be standardized messaging and information, which can build confidence among the technologist staff. And then finally, behavioral regulation as a domain points us towards the barrier of inconsistent response to concerns. And so that can be addressed by use of a clear protocol to guide actions. And then there are some expected outcomes from effective use of these mechanisms. The mechanisms themselves are a little conceptual. And so what did that look like in practice? So looking at the domain of knowledge, specifically the mechanism and the strategies used here were having staff attend mandatory training sessions and having leaflets and posters printed with the new practice guidelines. In our environmental context and resources category, patient shielding was removed from the X-ray rooms. So that was a way to modify the environment to change behaviors. However, the shields were still available to be logged out from a central location. Regarding the domain of beliefs around consequences, so standardized messaging to help support the technologists was drafted. And so In this regard, patient radiation safety, or hospital radiation safety and department work instructions were updated so that the new practice was compliant with the hospital regulations. Approval was also sought from the state regulatory community, so making sure that the practice is supported by both regulations and policies to protect the technologists in their practice change. And then behavioral regulation was assisted by ensuring that there was a protocol for the radiographers to address patient and family concerns, as well as modeling by senior staff. So many of us in the past, I don't know, 10 years or so have attempted to step away from patient shielding in radiography, and many of us have gone down this same path and this same journey and done many of these same things, but the benefit to using an implementation science framework like they've done here is that it's then publishable and can be shared with other places who are looking for how to best do this in their environment. The outcome chosen here was patient and family-centered outcome around a measure of frequency of inquiries about change in the shielding policy. So this would reflect how well the education and the script for the technologists had penetrated into the practice, and how comfortable patients and families were with the change. So beginning at the initiation of the project, the number of documented consumer queries from patients and families went down over the course of the project. So this was an important outcome of how well the change had been adapted and accepted by the patients and families. At the same time, the group also did measure the actual use of shielding, and even before the project began to really structure implementation of the change was already starting to happen. And so we see that the orange bars, which reflect shielding being applied, are trending down, while the blue bars reflecting cases with no shielding are trending up. So this was a practice change that was in process, and then implementation science strategies were used to help smooth that transition and to make sure that patients and families felt comfortable with the messaging and the practice change. So that's an example from pediatric radiology. The task that we're focusing on today includes changing our strategies for ultrasound, or changing our approach to the diagnosis of midgut volvulus. And there's abundant evidence that ultrasound is a good first-line evaluation for imaging examination for midgut volvulus. Abundant evidence in the literature, but how, again, to put that into practice is the problem that we're addressing. And our approach is a two-phase approach. Phase one is a quality improvement phase, looking to increase the diagnostic yield of ultrasound for midgut volvulus. So how often are we able to say, yes, there is volvulus, no, there is not volvulus? And overall, our beginning baseline is a bit low, and we're aiming for a 95% diagnostic yield. And we're using a tech coaching model to try to achieve that improvement. Phase two, which we are looking at beginning soon, is the implementation phase. So regarding the implementation science approach, so which we've just talked through, choosing frameworks, looking at barriers and facilitators, and selecting strategies that work in our environment is the phase two task. So that includes working with clinical partners to identify appropriate frameworks for change implementation, describing our barriers and facilitators, and selecting implementation strategies. So in summary, this field was developed in the 1990s to facilitate uptake of evidence-based practice. It's focused on understanding the environment in which the change will occur. The frameworks build a mental model for how the innovation interacts with the environment. Describing facilitators and barriers to change informs the approach. Strategies are used to promote uptake of the innovation. And as we've seen from the example here, implementation science can be effective to help integrate new practices in radiology. Some key references that I discussed here. And Thank you very much. I hope this has been helpful.